recording now. Hello, my name is Crystal, and today we will be doing a cardiovascular assessment. This is my patient. Do you give me permission for me to record this video and upload it to YouTube for my professor to review and grade?
Yes.
She verbalized yes. I wash my hands. I perform necessary precautions. My patient is safe. She's laying down in an about 30 to 40 degree angle. I've verified HIPAA, and I've also checked her blood pressure laying down and sitting up in both arms to compare them. From there, we're gonna go ahead and start with the inspection of the neck. Right now, we're looking for anything that's visible, anything that we could catch on by just looking at her neck, like edema, any trauma, pulsations of her carotid arteries. We can know if, if there's anything that's abnormal within her neck. From there, we're gonna go ahead and note her venous pressure. So we're gonna do that by locating her pulse, and we're gonna grab a card and lay that card out straight, and then locate her sternal notch up here and place a ruler upward, and that gives me number 2. So with that, it should be less than 3, which is normal. That's her venous pressure. From there, we're gonna go ahead and palpate her carotid. First of all, we're gonna inspect them, make sure that, like I said before, there's pulsations and everything. Now we're gonna go ahead and we're gonna look at her carotid. We're gonna inspect them, and from there, we're gonna palpate them. And what we're looking for is that pulsation. And we don't do them both at the same time because you can actually make your patient pass out. So we do it one at a time. We're going to also auscultate them for any thrills, any bruits. And we can auscultate them with the diaphragm and the belt of the stethoscope. Now we're going to move down to the inspection of the chest wall. So with the inspection of the chest wall, what I'm looking to see is if there's any pulsations, any visible pulsations that I can see. I'm looking at her sternum. I'm looking at her apical impulse. Looking at the precordial pulsation. See if there's anything that's visible that I can see with my eyes. From there, we're going to go ahead and we're going to start with palpation. So I'm going to palpate her point of maximum impulse. And that is located in the 5th intercostal space in the mid-clavicular line. So I'm going to go ahead and palpate that. I'm looking for that pulsation, that intensity. I'm looking for any thrills, any leaves. I'm going to go ahead and palpate her abdominal aorta, which is about 2 centimeters above her umbilicus. Again, I'm looking for any pulsations, anything that I can feel with my hands on that abdominal aorta. From there, we're going to go ahead and move down to auscultation. So with auscultation, we're going to go ahead and start at the aortic. And the aortic is located on the 2nd intercostal space in the right sternal border. So we're gonna locate her clavicle, and then we're gonna move down and start counting, and we're gonna find that 2nd intercostal space in the right sternal border, and that's where we're gonna listen to the aortic. We're gonna go ahead, place our stethoscope, and of course I would be doing this under her clothing. And what we're looking for here is for normal heart sounds, S1, S2, if there's an S3, S4. From there, we're going to go ahead and move on to the pulmonic, which is in the 2nd intercostal space on the other side, on the left sternal border. So this is the pulmonic. Erb's point is in the third intercostal space in the left sternal border. Tricuspid is in the fourth intercostal space. And then the mitral, which is in, like I mentioned before, fifth intercostal space, left sternal border, mid-clavicular line. And this is the point of maximum input. We can auscultate those areas, and we would do that again with the belt of the stethoscope and the diaphragm. So I did it with the belt, but we would also be doing it with the diaphragm. So we would go aortic, pulmonic with the diaphragm, Erb's point, tricuspid, and mitral with the belt of the stethoscope. And again, we're looking for any abnormal heart sound, splitting of S1, S2. When we hear S1 and S2, that is the closing of the mitral and the tricuspid valve. When we hear S2, that is the closing of the aortic and the pulmonic valves. Those are normal heart sounds. That's what we're looking for. Any abnormal heart sounds, like any murmurs, any S3, any S4, then that would be considered abnormal. From there, we're going to go ahead and auscultate for the splitting of S2. So we're going to go ahead and we're going to auscultate for that. And again, the closure of the aortic and the pulmonic valves, that's the closure. That's S2 sounds. And again, the splitting is best heard on inspiration. So I would go ahead and ask my patient to take a deep breath for me. Take a deep breath for me. And I would auscultate with the belt and the diaphragm of the stethoscope. Now I'm going to go ahead and I'm going to move down to what I palpated earlier, which was her abdominal aorta, which is located 2 centimeters above her umbilicus. And we're going to auscultate that as well. So we're going to go ahead and auscultate that with the belt and the diaphragm. And again, we're looking for any bruits, any abnormal sounds, any thrills that can indicate my patient may have an abdominal aneurysm. And I will let my patient know if she ever notes, sometimes you can see the pulsation, but if she ever notes that the pulsation is extremely visible, or if there's any pain, I can tell my patient to go see her provider. That's a patient instruction that I'm providing to her, because that could be a sign of an abdominal aneurysm. Now I'm going to go ahead and I'm going to look at my patient's extremities. I'm going to go ahead and inspect her hands. Here I'm looking at her fingers, any cyanosis, any nail hemorrhages, any clubbing of her fingers. I'm going to go ahead and check capillary refill on her fingers. And what I'm looking for is when I press down on her finger, that blanching, and when I release, that blood return should come back within less than 3 seconds. And there we go. That's what we have here. I'll go ahead and do it on the other hand as well. And there it is. We see that capillary refill, which that is considered normal. We can also check her extremities down at her legs for any edema, any veins, any edema, any venous problems that she may have. We can go ahead and also check capillary refill on her toes. Do the same, check capillary refill on her toes. See if there's any ulcers, any impairment of circulation. We can look at the warmth, take a look at feel the warmth of her leg. See if there's any discolorations, any ulcerations. Okay, let me make sure I position the camera correctly. Okay, from there we're gonna go ahead and we're gonna check her pulses. I'm gonna start with her radial pulses. Actually, no, let's start with her, I forgot the name, her temporal pulses. So we're gonna go ahead and feel the temporal pulses, make sure that they're present. We already assessed them, but we can assess them again. The carotid pulses, we assess them bilaterally. We could check our patient's brachial pulses right here. And again, we will do it on the other arm as well. Check for the brachial pulse. We can go ahead and check her radial pulses. From there, we would move down. Let me just place the camera over to the side, make sure we get a good view. There we go. Okay, from there, we're gonna go ahead and check her femoral pulses right here. From there, we're gonna go ahead and do the popliteal pulses. And also we have to do the tibial and the dorsal pedalis. So the tibial is right here, and the dorsal pedalis we will find right up here. So we're just making sure that all those pulses are present when we are doing our cardiovascular assessment. For the femoral pulses, we want to make sure that we auscultate those. So we're going to go ahead and auscultate the femoral pulses with the bell of the stethoscope, and with the diaphragm. And with that, we would be concluding our cardiovascular assessment. Thank you for watching, and we'll see you again next week.